sit up straight. All right, so you're basically inspecting what one side look like the other, right? You see anything out of the ordinary? Everything look equal on both sides? You can slip that your name tag on. It's kind of throwing me off. I love my job. All right, so nothing looks abnormal, left side, right side. Everything's symmetrical, right? Okay, so inspection, palpation. If he's a bad patient, he's going to go, this all hurts. Okay, and it may hurt, but what hurts the most with one finger, point to one area. So if he points right here, what do I think he has?
AC joint.
Well, he has an AC joint, of course. AC injury, okay? And you've already known this from his history because he said he fell down when he was mountain biking, right? So, AC joint, okay? If he points here, SC joint injury type thing, okay? You know, if he points here, elbow, or he could have, you know, referred pain, okay? So that's type thing. So the first thing you want to do, we inspect, we palpate, but you don't want to palpate if he's painful here. I don't want to palpate here first because if I keep mashing on that, which we tend to do, what is that? Well, let me think what that is. We all do it. I still do it. So, oh, okay, quit pressing on. Go everywhere else, press everywhere else. Then the last point is where they're painful. They're going to say, Doc, the shore's right here. I know, but let me check. Let me be complete. I'm a holistic doctor. Let me check complete. I was throwing it in. Okay. A buddy of mine is anybody that wants to do dermatology and or cosmetic dermatology. One of my fraternity brothers is a big-time DO dermatologist up in Buffalo. He had all these MD derm residents in there. He's throwing out holistic, and you should take the whole patient and treat the patient, all this stuff. And he's looking at me, and I'm like, exactly. That's okay. She knows what's up. All right. So inspection, palpation, range of motion. So range of motion wise, go ahead and stand up for me. Okay. So you want to do active and passive. Active is this. Raise all the way up to the top. Okay. Come on back down. Okay. Off to the side. All the way up. Well, you didn't have to walk up. I just walked up. Okay, now do this. Okay, I can't do this, nor probably most of you can't either. Okay, so this is better. All right, because you get junk out of the way when you do that. All right, so we already did flexion, right? We always did Steeler touchdown. Touchdown, Steelers, okay? Too many of those. They go back like this. Okay, so that's active range of motion. Looks great. Looks like he can do everything. Now you want to do passive range of motion, okay? Because say he can do this, but he gets stuck right here. Next thing we had somebody in the first class that actually got stuck, so we brought him up here and showed the pathology. But so as he comes up here, he can't do this anymore. Is it because he loses strength there, or is it because he has something blocking there? So like a labrum or something. So you do it. So just let me do it. Oh, look, I can do that, but he can only get to here. So it may be, I'm not hitting any restrictions, so it's probably not a blockage, it's probably lack of strength. So go ahead and push against me. Okay? Now, obviously, he's full strength. But say he got to here and he can't do it anymore. That's more of a muscle injury or a nerve injury firing that muscle. So that's why you do everything actively and passively. Actively, passively, 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 okay? Then you want to do strength testing, okay? Hold your arms like this. Keep your elbows in. Okay. Push out like this. Okay, push in. Okay. Push forward. Your arm. I'm sorry. Okay, good. Go backward. Okay, push out. You can do it with the, you know, I was doing it with his arm straight. You can do it with his elbow bent. Go all the way up. You can do it as push up. Okay, so you're checking all the muscles when you do that, all right? So then, sensation-wise, you feel this the same on both sides? Same on both sides. Same on both sides. Okay, you'll get to know dermatomes in term 3. You know your dermatomes is actually in this PowerPoint. You get to know your dermatomes. Okay, and you do reflex testing as well. Okay, with your tomahawk chop, Levitsky hammer that I have, C5, C6, C7. Okay. So I've done that. So inspection, palpation, range of motion, actively and passively, neuro testing, muscle testing, and then also vascular. Radial pulse, light is good. Okay, we've done that. But before or after you do all that, go to have a seat. We want to do Sperlings and Lhermitte's. Because remember, referred pain, and I guarantee you, you're going to see people in your office that they went and saw some other doctor, and they had the person came in with shoulder pain. They did an MRI, they did X-rays, everything's come back normal. They just say it's bursitis. Here, take some anti-inflammatories. The person continues to have it. So they come to your office and you do this. Any neck injuries? No. Okay, let's do a Sperling's test. So Sperling's test. Do you have any neck injuries? Okay. Do you mind me squashing your head? Okay. So I rotate and think of the spine in the back. Okay, think of all the discs in between, the nerves coming out. What I'm trying to do, I'm trying to press on those to see if I get any radicular pain, any sharp stabbing pain down the arm. Not pain in the neck, sharp stabbing pain down the arm. Okay, so I rotate, hyperextend, and side bend. Any pain? Okay. If you get to that point and you have no pain, add one more step, kind of kick it up a notch. Push actually down. You're not pulling his head back. You're pushing hands up. Most people do this wrong. You're going to see some doctors in the office do this wrong. They do it like Frankenstein test. Okay? Let's do the empty cam first. Let's do UGA first. Okay? Boo. Okay? None of my teams are doing good, so I can't even say it. So, this would be wrong. You'll see doctors doing this. Okay? Push up. Okay? That's wrong. You want them to be 30 degrees of scaption to do it. Okay? Because that way, you're loading the supraspinatus. If you do this, they could have a false negative because you're activating other muscles. So you want to be in scaption where the scapulas are in an angle, 30 degrees, and don't let me push down. You can either do it here, or you can do it here, okay? I tend to do it here. Particularly the guys I work with, I do it here, they're going to throw me across the room. So I do it here just to get better leverage, okay? Don't let me push down. Okay, what strength is that? We had to grade strength. What graded strength does he have? Really? How do we grade strength? Come on. Musculoskeletal, we tried musculoskeletal medicine? 5 out of 5. It's full strength. What's no strength? 0 out of 5. Oh my God. 5 out of 5, 0 out of 5. Okay, put your arms up like this. Okay, so what's that strength without me even touching it? But if I do this, it drops. So strength against gravity. What's strength against gravity? 3 out of 5. Okay, so 5 out of 5 full, 0 out of 5 none. 3 out of 5 against gravity. The 1 and the 2 is kind of a flicker type thing. 4 out of 5 is, it's this. Push it. That's 5 out of 5. 4 is like a little bit, but he still holds it up. Okay. And I add 4 plus and 5 minus, and I do all that kind of crazy stuff. But just know 5 out of 5, 0 out of 5, 3 out of 5, and then in between. All right. So, okay, up again. Thumbs down. He's not pushing, or I can't break him. 5 out of 5. Supraspinatus, right? But what can I also test by doing that? Because what am I doing when I internally rotate? What muscle is also activated? Supraspinatus, maybe? So, I do a full can test, which in medical school, when I was in medical school, I know back in the day, dinosaurs were walking around, airplanes, Flintstones driving down the street. So, full can test we didn't do, but now they figured out that you can actually have a false negative by doing the empty can. So you do the full can, which actually takes the infraspinatus out of the picture. Don't let me push down. Okay, now 5 out of 5. Very good. Okay, so that's the empty can, full can, and that's the reason why you do the full can, take the infraspinatus out. Okay, so empty can, full can. External rotation. Come on. Here's mine. Internal rotation. Subscapularis. Okay. Push up again. Flexion. Bicep, shoulder line. Anterior delt. Push back.
Posterior delt.
And what's extension? Posterior delt. There's some rotator cuff involvement as well, but okay. So you've already tested that. Now let's test specifically while we're here. Let's do the liftoff test. Okay, the liftoff test. Turn around this way. I used to call the Michael Blüt test. Okay. Okay. Just because dogs fighting and all that stuff. That's why. Okay. Now push out again.
Getting arrested test.
That's full strength. Now push down. Okay. So what's he doing when he does this? Externally rotating. When he's doing this? Internally rotating. Okay. What if he can't get his arm back there for whatever reason?
Strict.
Can you still do this test another way? If you look at the PowerPoint, you can. Okay, turn around. Okay. Napoleon test. Okay. Push out is what? External rotation, push in. Internal rotation. So, external rotation is what? Muscle? Just talking. There it is. Internal rotation. Sub-scap. Okay? So that's the specific test, or if you're doing testing, it's still you're doing the same thing, right? So that's those tests.
What do you say was internal?
So we've done supraspinatus, infraspinatus, teres minor, sub-scap, all right? Now, with special tests, now we want to jump to the impingement test, okay? Because we're still standing. The impingement test, what's the most common dislocated shoulder position? Anterior inferior, because there's nothing that lives up here except soft tissue, right? So that's easiest to dislocate. You didn't dislocate. So, apprehension test, if you looked at Hoppenfeld, there's an interesting picture, which is a stupid little drawing picture, but it shows a person with apprehension. So if I'm anterior inferior dislocation, if I do this enough, I'm going to anterior inferior dislocate. Okay, I've done it. So as you do this on your person, as meeting the doctor, you're the patient, put your hand right here. Okay. Now, what happens when I go back like this? What does it feel like in front? Yeah, so he has an intact capsule, anterior capsule, so it's trying to push forward, but the capsule's not letting it, all right? And he can feel that. So when you guys do it on each other, make sure you feel that. So who's dislocated in here? Anybody? Okay, so when he does it, make sure you feel that, because he's probably going to have a little apprehension. Did you get surgery? Okay, so he's going to actually have a little apprehension test. Don't dislocate him, because I don't want to teach you guys how to relocate. All right, so, not yet at least. Right, so if he's dislocated, ooh, doc, ooh, I'm not comfortable with that, ooh, and he starts grabbing his shoulder because, he doesn't want it to dislocate, right? So, that's the apprehension test, okay? Now, jumping now to, since we're still standing, jumping now to impingement test. Well, first impingement test is the Hawkins test, okay? Hawk, the Atlanta Hawks. Okay, I don't know who goes to those anymore, but Atlanta Hawks. Okay, well, Tom Outman, I could be talking like this, and the person on the other side could hear me talking. That's how many people were there. Right, so, and I don't know once because I'm not a big basketball fan. Right, so, I had free tickets. So I flex my elbow, college basketball, flex my elbow, AB duct, or AD duct, internally rotate, okay? Usually, when you get people to hear, ow, 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 ooh, I don't like that, okay? Don't come out here and do it. Make sure you cross-body them, and then come down. That's impinging. Think about that acromion digging into that supraspinatus. That's basically what you're doing, okay? So that's Hawkins test. The near test is near to the ear. Thumb up, stabilize the scapula, near to the ear, okay? Now thumb down, okay? Now I'm already impinging with him internally rotating, and he's already impinging if he impinges. And then near to the ear. But you got to stabilize the scapula when you do it, because if you just do this, his scapula is lifting, so he's less impinging, okay? So you want to push this down to make sure that's not playing a part in it. Then near to the ear, I have impingement test, okay? That's 2 impingement, Hawkins and ears, okay? So I did apprehension, okay, instability test, Hawkins, ears, okay? Another instability test is the anterior posterior translation. So, what I do